Welcome to The Critical Edge, the no-nonsense podcast, breaking down the latest game-changing evidence in trauma and surgical critical care to give you the edge when things get critical.
Thanks for having me back.
So today we are doing a deep dive into something that honestly gives a lot of trauma surgeons massive anxiety. We're getting into Desai and Thaler's comprehensive surgical algorithms for maxillofacial trauma.
Yeah, anxiety is the right word
Mm-hmm.
because imagine you were standing at the foot of the bed in the trauma bay.
Right.
EMS rolls in a high-speed MBC, unrestrained driver,
Right.
and the presentation is just catastrophic.
Oh, yeah, massive midface smash.
Exactly. You've got active hemorrhage from the nares, blood pouring into the oropharynx, completely distorted anatomy,
Yeah.
and the patient is combative, hypoxic, and, rapidly losing their airway.
It is basically the clinical equivalent of a smoke grenade.
A smoke grenade. That is a perfect way to describe it.
Right, because the sheer visual trauma of a pulverized face, it's designed to be overwhelming. You've got the blood volume, the noise, the distortion of recognizable human features.
Yeah, it's terrifying to look at.
And it aggressively pulls your attention away from the systematic evaluation we rely on. You get tunnel vision.
You do. But, and this is the crazy part, the data from Desai and Thaler makes one thing abundantly clear. Maxillofacial trauma, when it's isolated strictly to the face, it almost never kills the patient directly.
Right, really? Almost never.
Almost never. The mortality actually stems from what the facial trauma is hiding.
Right. The smoke grenade obscures the ABCs.
Exactly. The immediate lethal threat isn't the shattered zygoma or, the Lefort 3 craniofacial disjunction.
It's the airway.
Yes, it is the cascade of mechanical failures compromising the upper airway. And, well, the massive superficial hemorrhage that's threatening hemodynamics and causing aspiration.
So our mission for this deep dive is cutting through that visual noise.
Right. We are translating all that anatomical architecture into an actionable bedside strategy for you, the trauma surgeon.
Because we have to secure that airway first, arrest the hemorrhage, and then map out the definitive reconstruction.
And that reconstruction isn't just cosmetic. It's about restoring absolute premorbid occlusion, aesthetic symmetry, and structural functions.
Right, so let's start with the absolute first priority, the airway.
Yeah, the A in ATLS.
Because securing that airway requires an immediate understanding of the biomechanical failures happening right in front of you. Like, it's not just passive edema, right?
Yeah, no, not at all. When a patient sustains a comminuted mandibular or maxillary fracture, you are looking at a complete loss of structural anchoring.
Like the genioglossus muscle.
Exactly. The genioglossus is intimately secured to the lingual surface of the mandibular symphysis, right there in the front of the jaw.
So if you have a bilateral parasymphyseal fracture,
Which shears that bone away from the main arch of the mandible.
that anchor is entirely obliterated.
Poof, gone. And the structural integrity is lost, so gravity immediately takes over.
Wow.
Yeah, without that anterior bony anchor, the tongue just physically descends backward into the oropharynx.
Creating an immediate, dense mechanical obstruction.
You got it. And, this rarely happens in a vacuum. You are compounding that descending tongue with massive, rapid onset edema.
And pooling blood.
Pooling blood from valveless facial veins, which we'll get into. Plus, often emesis or shattered dentition acting as foreign bodies.
And if you add an altered mental status to that equation, which is super common.
Oh, absolutely. Concurrent traumatic brain injury is highly prevalent in these mechanisms, or acute intoxication.
Right. So their protective gag reflex is blunted or just completely absent.
Which means the clinical exam in that moment has to be hyper-focused. You listen for stridor, which flags the narrowed upper aerodigestive tract.
You watch for cyanosis.
And drooling. Drooling is an absolute red flag.
Because if they cannot manage their own baseline salivary secretions,
They certainly cannot clear an expanding pool of blood or gastric contents. That dictates an immediate definitive airway.
but the route of that definitive airway, that's where I see trauma surgeons encounter a massive clinical trap.
You're talking about nasotracheal intubation.
Exactly. With midface instability, like any suspicion of a Lefort pattern or severe nasoethmoid complex disruption, nasotracheal intubation is an absolute contraindication, right?
100%. The anatomy of the upper vault is just too fragile. If you pass a tube blindly through a shattered nasal cavity, you risk violating the cribriform plate.
Which means you are literally intubating the anterior cranial fossa.
Yes, you're putting a tube into their brain.
Which is obviously catastrophic.
Plus, even if you don't hit the brain, The trauma of the tube passing through lacerated nasal mucosa will provoke severe hemorrhage. It'll instantly obliterate whatever view of the cords you might have had.
So orotracheal intubation is the definitive primary maneuver.
Yes, often requiring rapid sequence induction.
But what if the regional trauma is so severe, like the mandible is floating, the hemorrhage is torrential, and the edema prevents any visualization of the glottis?
Then you abandon the oropharynx immediately. You move directly to a surgical cricothyrotomy.
No hesitation.
Zero room for hesitation when the supraglottic architecture is destroyed. You just cut the neck.
Okay, so the tube is secured and verified. Now the physiological focus shifts immediately to hemorrhage control.
Right, the bleeding. And the facial vascular network presents a really unique hemodynamic challenge.
Because it's derived almost entirely from the external carotid artery.
Exactly. And the anastomotic network is incredibly dense and very superficial.
Which accounts for the profound volume of blood loss in the initial presentation. That's the smoke grenade effect again.
Yeah, exactly. But interestingly, that same rich anastomotic network is actually your greatest asset.
How so?
Because the collateral flow is phenomenal. So ligation of these superficial bleeding vessels, or just applying sustained direct pressure, very rarely induces ischemia in the adjacent facial tissues.
Oh, wow. So you don't have to worry as much about necrosis from pressure.
Right, and you absolutely do not need to blindly clamp in a bloody field.
Because that runs a massive risk of crushing the facial nerve branches, right?
Or the parotid duct. Yes, blind clamping is a huge mistake. Broad, continuous direct pressure for a minimum of 30 minutes is the mandate for superficial facial bleeding.
30 minutes, no peeking.
No peeking. Peeking at the wound every 5 minutes disrupts the fragile platelet plug forming at the endothelial level. It just resets the clock.
Now, I want to talk about the venous bleeding because the mechanism requires a specific approach to that pressure. The facial venous system is valvulus, right?
Yes, it communicates deep into the cavernous sinus to regulate intracranial temperature.
And in the setting of a laceration, this valvulus architecture means you have bidirectional flow.
Exactly. Blood-free flows from both the proximal and the distal ends of the lacerated vein. There is no venous valve to spasm shut and halt the retrograde column.
So it's essentially a plumbing system with no backflow preventers.
That is a perfect analogy.
So how does that change the physical approach to applying pressure? You can't just apply focal pressure proximal to the wound like you would with brachial or femoral bleed.
Right? No, you can't. The tamponade must be broad, firm, and applied continuously over the entire wound bed to mechanically collapse those valvulus channels.
And what if you have large caliber arterial bleeding that fails pressure?
Then that repair happens under controlled conditions in the operating room. Never blindly in the trauma bay.
Got it. Okay, so that brings us to epistaxis, which bridges the gap between hemorrhage control and airway protection.
Yeah, because the nasal cavity is a highly vascular cavern sitting directly superior to the unprotected airway.
For anterior bleeding that fails 30 minutes of external pressure, methodical packing is required.
Right. You use a nasal speculum to elevate the nares, and you use bayonet forceps to meticulously layer ribbon gauze impregnated with petroleum jelly.
And the technical pearl here is pressing firmly after each successive layer to achieve true mechanical tamponade.
Yes, but, and this is a big but, the surgeon has to balance the pressure against the risk of iatrogenic injury.
Because overpacking can rapidly induce pressure necrosis of the delicate septal mucosa.
Exactly. Yeah. If you have direct visualization of an isolated bleeding vessel, silver nitrate cautery is highly effective.
But posterior bleeds are a different beast entirely.
Oh, they are much more insidious. They dump massive volumes of blood directly down the posterior pharynx.
So posterior packing is mandatory.
Mandatory. And while commercial nasal balloon catheters are ideal, a standard 10 to 14 French Foley catheter is a highly effective, ubiquitous alternative.
Right, because everyone has a Foley. So you pass the uninflated Foley through the nares into the oropharynx, inflate the balloon, and retract it anteriorly to firmly plug the posterior choanae.
Yes. But this is where we see significant iatrogenic morbidity. The inflation volume is exactly 10 milliliter.
Exactly 10.
Exactly 10. The instinct, particularly for junior staff managing a torrential airway bleed, is to overinflate the balloon to 15 or 20 milliliter.
Because they assume more pressure equals better hemostasis.
Right, but it's a huge clinical trap. The posterior nasal anatomy is rigid bone lined with thin, unforgiving mucosa.
So if the outward pressure of that balloon exceeds the capillary perfusion pressure of the mucosa,
You induce rapid ischemic tissue necrosis. You trade a manageable acute hemorrhage for the long-term structural destruction of the posterior nasal cavity.
Wow, so you inflate to 10 millil, secure it anteriorly, and if bleeding persists, what do you do?
You rely on counterpressure from anterior packing, not balloon hyperinflation.
That is such a critical pearl. Okay, so with the ABC stabilized, the secondary survey requires a highly targeted AMPELI history.
Right. Allergies, meds, past history, last meal, events. And the mechanism of injury provides profound predictive value regarding the underlying structural failure.
Like high-velocity mechanisms, motor vehicle collisions, ballistic trauma.
Those correlate heavily with panfacial fractures. You need a high index of suspicion for multi-level craniofacial separation.
Whereas sports-related blunt force typically localizes to the upper midface.
Exactly, yielding isolated zygomatic or nasal fractures.
And then assault or interpersonal violence is highly predictive of unilateral mandibular fractures.
Classically from a lateral blunt force impact to the parasymphysis or the angle of the jaw.
Now, I often see pushback on gathering the last meal data during the AMPL history for facial trauma. People view it as secondary to the immediate physical injuries. Like, does it really matter what they ate for breakfast if their jaw is shattered?
It matters immensely. In this specific population, the timing of the last meal dictates critical downstream management.
Because of aspiration risk.
Exactly. These patients are at a massive risk for aspiration pneumonitis from pooled blood and secretions. If their definitive management requires intramaxillary fixation, meaning wiring the jaws shut, or if they need recurrent anesthetics for staged reconstructions, a full stomach fundamentally alters the risk stratification and the sequence of airway protection.
Okay, that makes perfect sense. So after the AMPL history, the physical exam must be dynamic and quantified. You don't just ask the patient to open their mouth, right?
No, you measure jaw excursion. Normal vertical opening is 4 to 5 centimeters, and lateral excursion is about 1 centimeter.
And a deficit there indicates mechanical impingement.
Often a depressed zygomatic arch physically blocking the coronoid process. Or it could be severe muscle spasm.
And you're palpating the entire facial skeleton for step-offs, crepitus, and checking cranial nerves.
Right, and you have to do all of this before the onset of massive edema, because that edema will accumulate rapidly.
Right, a patient who is clinically stable at hour 1 can develop critical airway compromise from delayed soft tissue swelling by hour 4.
Continuous reassessment is mandatory until definitive imaging is complete.
Which is axial and coronal thin slice CT, paired with a Panorex for dentition.
Gold standard.
Okay, so once the imaging confirms the architectural damage, the surgical focus transitions from the inside out, starting with the soft tissue envelope.
Because the underlying bony reconstruction relies entirely on the viability and aesthetic alignment of this soft tissue drape.
And local anesthesia management is the first critical step there.
Right. We utilize lidocaine for immediate effect and bupivacaine for prolonged 2 to 4 hour coverage.
And the toxicity thresholds are super rigid.
Very rigid. 1% lidocaine maxes out at 4.5 milligicoligrams, but the addition of epinephrine pushes that threshold to 7 milligicoligrams.
And the pharmacology of that epinephrine addition is essential for the trauma surgeon operating on the face, isn't it?
It's vital. Epinephrine induces profound local alpha-1 receptor vasoconstriction. This physically confines the lidocaine to the injection site.
So it restricts its systemic absorption into the central circulation.
Exactly. This delayed absorption drastically mitigates the risk of systemic cardiac dysrhythmias and neurotoxicity while simultaneously extending the duration of the anesthetic block.
Plus, clinically, it provides significantly drier surgical field.
Yeah, by clamping down the superficial capillary beds, it allows for meticulous microscopic repair.
Which you absolutely need. Now, what about antibiotic prophylaxis?
Also rigid. First-generation cephalosporins are administered within 30 minutes of initiating repair. Clindamycin for penicillin-allergic patients.
And the coverage must be tailored to the exact mechanism and anatomical location, like any laceration communicating with the oral cavity.
Mandates the addition of robust anaerobic coverage to counter the massive bacterial load of the human mouth.
And animal bites.
Particularly canine, require broad-spectrum coverage targeting both gram-negative organisms and anaerobes. The goal is primary closure within 6 to 8 hours, though highly monitored wounds can occasionally be stretched to 24 hours.
Okay, so let's get into specific repairs, because the techniques dictate the final aesthetic and functional outcome, and the lip is notoriously unforgiving.
Oh, the lip is brutal.
Hey.
The vermilion border, the junction of the cutaneous lip and the red mucosal lip, is a highly visible aesthetic landmark. A misalignment of even 1 millimeter is glaringly obvious.
It's like trying to match the seams on a tailored suit while the fabric is actively inflating.
That is a brilliant way to put it, which is why the procedural mandate is to use methylene blue to tattoo the surgical margins of the vermilion border before infiltrating any local anesthesia.
Right, because if you inject the anesthetic first, the hydrostatic pressure of the fluid balloons the tissue.
And you completely distort the border. You lose your anatomical map before you even make the first suture pass.
So once tattooed, the closure is layered.
Yes, absorbable braided sutures reapproximate the orbicularis oris muscle to restore oral competence. Chromic gut is used for the wet mucosa, and fine non-absorbable sutures align the skin.
Got it. Now, moving inward to the tongue, lingual lacerations require a different triage, right?
Yeah, because while superficial tongue lacerations often heal well by secondary intention, deep lacerations harbor a hidden airway threat.
Because of the lingual artery.
Exactly. A deep laceration can transect the lingual artery if this vessel retracts and bleeds into the closed space of the floor of the mouth,
The hematoma forces the tongue up and back.
rapidly occluding the oropharynx. These require aggressive exploration, direct ligation of the bleeder, and layered muscular closure.
And what about the ear? Auricular trauma demands specific attention to the cartilage.
The ear must be repaired within 12 hours. While you do not necessarily need to reapproximate every shattered piece of fiber cartilage, you are absolutely required to utilize bolsters.
Typically petroleum-impregnated gauze sewn directly through the full thickness of the ear. Why is that so critical?
Because the anterior skin of the ear is tightly adherent to the underlying perichondrium, which supplies the avascular cartilage with its entire blood supply.
So if shearing forces strip that skin away,
A subperichondrial hematoma forms in the dead space. This hematoma acts as a physical barrier, stripping the blood supply from the underlying cartilage,
causing rapid ischemic necrosis.
resulting in a permanent fibrotic cauliflower ear deformity. The bolsters act as a continuous physical clamp, compressing the skin tightly against the cartilage, obliterating the dead space, and preventing hematoma accumulation.
Okay, that makes sense. Now let's talk about the lateral face because it houses a complex intersection of glandular and neurological structures.
Specifically the parotid gland and the facial nerve.
And parotid injuries carry massive morbidity.
Massive. A mistransection of Stenson's duct results in saliva pooling directly into the cheek, expanding into a massive sialossal, or tracking outward to form a chronic, draining salivary fistula on the facial skin.
Which is where the Lukovich algorithm comes in, right? For any deep laceration crossing the trajectory of the duct.
Exactly. Roughly a line connecting the tragus to the mid-upper lip. You must cannulate Stenson's duct intraorally and inject saline or methylene blue.
And if the fluid extravasates into your external facial wound, the duct is definitively transected.
Yes. And the repair protocol requires identifying both severed ends within the parotid parenchyma, performing a primary microscopic anastomosis over a stenting catheter, applying firm external pressure for 48 hours, placing an intraoral drain for a week, and maintaining the internal stent for 14 days.
All to prevent fibrotic stricture of the duct.
Exactly.
Now, running right through the substance of that parotid gland are the branches of the facial nerve.
Right. And deep lacerations here frequently involve nerve transection.
So how do you handle a situation where the facial nerve might be injured, but the field is too bloody to tell? Do you go digging for it?
Absolutely not. The mandate here is absolute restraint in the emergency department. The field is highly vascular and typically obscured by blood. Digging blindly for severed nerve ends in the trauma bay is a guaranteed way to convert a temporary neuropraxia into a permanent, irreparable transection.
So you just halt the exploration.
Yes. If there is clinical weakness or the anatomical depth raises high suspicion, you stop. The patient goes to the operating room, a bloodless field is obtained, and the nerve is repaired acutely using loop magnification or a surgical microscope.
Okay, so with the soft tissue envelope managed, we dive into the structural scaffolding, starting at the apex of the face, the nasal bones.
The most prominent and frequently fractured architecture in the facial skeleton. The nasal pyramid relies on internal fusion with the perpendicular plate of the ethmoid bone for structural support.
And given its prominent position and relatively fragile cortical thickness, it absorbs immense kinetic energy.
And the mechanism heavily dictates the fracture pattern. Lateral impacts, like a punch, tend to displace the bones laterally, which is generally easier to reduce.
But a direct anterior to posterior impact
Is far more devastating. It telescopes the nasal bones directly backward, crushing the ethmoid complex and causing severe midface flattening.
And demographics play a big role here too, right?
Oh, absolutely.
Yeah.
We see these most commonly in males in their 20s and 30s. Pediatric patients who have a higher ratio of flexible cartilage frequently sustain green stick fractures. Conversely, osteopenic elderly patients sustain highly comminuted shattered fractures.
Now, diagnosing these is purely clinical, right? Like there is absolutely no indication for plain radiography or dedicated CT scans solely to diagnose an isolated nasal fracture.
None at all. The imaging does not alter the management algorithm. The immediate clinical priority is examining the septum for a hematoma.
Because much like the ear, a septal hematoma strips the blood supply from the underlying septal cartilage.
And left undrained, the cartilage necroses rapidly, leading to a catastrophic loss of dorsal support and a permanent saddle nose deformity.
Right. And the timing of the bony reduction is constrained by two very specific physiological windows. I liken it to setting wet concrete.
That's a good analogy. The first is the golden window, within the first 3 hours post-injury. This is prior to the onset of massive soft tissue edema. You can accurately palpate the bony contours and perform a closed reduction.
But if you miss that 3-hour mark, the edema obscures all the anatomical landmarks.
Right, so you are forced to wait for the second window, which opens between 3 and 10 days once the swelling is resolved, but before fibrous union occurs.
And if you delay past 10 days, the concrete is locked.
Yes. Fibrous connective tissue begins to organize and solidify within the fracture lines. The malaligned bones effectively lock into their displaced positions. A simple closed reduction using elevators is no longer viable, and you are forced into a delayed open rhinoplasty approach with osteotomies to re-break and reset the bones.
So you either do it immediately, wait a few days, or you're doing major surgery later.
Exactly.
Okay, moving laterally from the nasal pyramid, we encounter the primary buttress of the midface, the zygomatico-maxillary complex, or ZMC.
Desai and Thaler refer to this as a tetrapod fracture.
Right, which is an incredibly accurate biomechanical descriptor, because the zygoma itself is an exceptionally dense, thick mass of cortical bone. It acts as the load-bearing pillar between the fragile maxilla below and the robust cranium above.
Because of this density, blunt force rarely shatters the body of the zygoma itself. Instead, it turns the bone into a battering ram.
The kinetic energy transmits directly through the dense zygomatic body and focuses on its 4 weaker sutural attachments.
The zygomatico-frontal, zygomatico-temporal, zygomatico-maxillary, and zygomatico-sphenoid sutures.
The 4 legs of the structural table.
And they snap simultaneously. And the dense tabletop collapses inward and downward, typically plunging directly into the maxillary sinusoid orbit,
making it a tetrapod fracture rather than just a tripod. Now, the clinical presentation is highly distinct. Patients exhibit profound trismus, right?
Yes, and this isn't just pain-related guarding. The depressed zygomatic arch is physically pinned against the coronoid process of the mandible, or it is directly impinging the temporalis muscle,
creating a hard mechanical stop-to-jaw excursion.
They also present with hypoesthesia in the V2 distribution. The fracture line invariably propagates through the infraorbital foramen, stretching or shearing the infraorbital nerve and numbing the cheek, lateral nose, and upper lip.
And aesthetically, malar flattening is the hallmark sign, though massive early edema can completely mask the depression for several days.
Which is why axial and coronal CT imaging is mandatory to quantify the degree of rotation and displacement. The surgical goal is absolute restoration of the anterior projection and the vertical height of the malar eminence, usually requiring rigid fixation at a minimum of 2 and often 3 of those sutural pillars.
Because the zygomatico-sphenoid and zygomatico-maxillary articulations form the lateral and inferior walls of the orbit, a displaced CMC fracture almost inevitably leads us to the delicate structures housing the eye.
Right, which brings us directly to the complex mechanics of orbital blowout fractures.
The orbit is basically a trapdoor designed to fail.
Exactly. It's a bony cone, heavily fortified at the rims, but incredibly fragile internally. The orbital floor is concave centrally, sloping upward as it runs posterior.
But the optic canal housing the optic nerve is positioned posteromedially in the thickest bone, shielded from all but the most catastrophic skull-based trauma.
Thank goodness. The pathophysiology of a blowout fracture is basically an exercise in fluid dynamics and pressure transmission. When a blunt object strikes the globe,
the intraorbital pressure spikes exponentially.
Because the globe is fluid-filled and non-compressible, the dense orbital rims absorb some energy, but the kinetic wave follows the path of least resistance,
which leads directly to the paper-thin bone of the orbital floor and the medial ethmoid wall.
And the bone physically blows outward, into the air-filled cavities of the maxillary and ethmoid sinuses.
The orbital floor acts as an evolutionary pressure release valve. It is designed to fail outward, instantly expanding the volume of the bony orbit to dissipate the pressure wave.
You're sacrificing the bony floor to prevent the globe itself from rupturing, but that preserved vision comes at a severe biomechanical cost.
Because with the floor gone, gravity and the pressure gradient force the orbital fat, and occasionally the extraocular muscles, to herniate down into the maxillary sinus.
Which causes an ophthalmos, a sunken, posteriorly recessed globe, and hypothalamus, a downwardly displaced globe.
But the most functionally debilitating complication is diplopia, right?
Absolutely. When a patient looks upward and experiences double vision, you have to immediately differentiate between two distinct etiologies.
Is the inferior rectus muscle merely contused and suffering from temporary neuropraxia, or is it physically entrapped within the bony fracture line?
And forced duction testing is the definitive diagnostic maneuver here. You anesthetize the conjunctiva, physically grasp the sclera with toothed forceps, and attempt to manually rotate the globe upward.
If the globe rotates freely with no resistance,
The muscle is intact but suffering from edema-induced neuropraxia. You observe and allow the swelling to subside.
but if you encounter a hard mechanical stop,
The inferior rectus is physically incarcerated in the fracture, and entrapment is a surgical emergency, particularly in pediatric patients who frequently suffer trapdoor fractures.
where their highly elastic bones snap outward, the muscle drops in, and the bone snaps back into place, severely pinching the muscle.
Exactly. This pinch occludes venous outflow while arterial inflow continues, rapidly inducing compartment syndrome within the muscle belly. Left unreleased, the muscle undergoes rapid, irreversible ischemic necrosis.
So how exactly do you retrieve that herniated orbital fat from the maxillary sinus without causing further ischemia to the entrapped muscle?
It requires meticulous dissection. You typically access the floor via a transconjunctival or subciliary incision, and you cannot simply grasp the herniated tissue in the sinus and pull it upward. The traction will shred the ischemic muscle fibers.
So you have to go around it.
Right. You carefully elevate the periosteum around the defect, tease away the pinching bony fragments, and gently guide the orbital contents back into the vault. Once reduced, you span the defect with a rigid alloplastic implant or an autogenous bone graft.
Effectively building a new floor resting on the stable peripheral bony ledges.
Yes. But the choice of incision carries distinct risk profiles. A subciliary incision made through the skin just below the lash line risks cicatricial outward scarring.
Which pulls the lower eyelid downward, creating ectropion.
And that exposes the sclera and leads to severe corneal desiccation. Conversely, a transconjunctival incision hidden on the inside of the lid avoids the external scar but risks inward fibrotic contraction.
Causing entropion where the eyelashes turn inward and continuously abrade the cornea.
The margins for error in the periorbital soft tissue are just microscopic.
Okay, transitioning from the midface down to the lower third, we encounter the only mobile bone of the facial skeleton, which presents its own unique engineering challenges. The mandible.
The mandible is a dynamic, load-bearing bone, and the absolute primary mandate in its reconstruction is the exact restoration of the patient's premorbid dental occlusion.
So the way their maxillary and mandibular teeth interlocked before the impact is exactly how they must interlock postoperatively.
Exactly. Even a single millimeter of occlusal discrepancy alters mastication, speech, and induces severe chronic temporomandibular joint dysfunction.
Structurally, the mandible is treated like a long bone, necessitating rigid internal fixation.
It's an arch composed of dense cortical bone surrounding a softer cancellous core. The inferior alveolar artery and nerve run directly through a central bony canal.
Which is why ipsilateral numbness of the lower lip and chin is the hallmark clinical sign of a fracture. The shearing force stretches or severs the nerve within its tunnel.
Right, and the fracture patterns follow distinct anatomical weak points. The angle of the mandible accounts for roughly 34% of fractures.
And this is heavily influenced by the presence of a third molar, the wisdom tooth.
Yeah, because it creates a massive hollow void in the otherwise dense cortical bone, acting as a stress riser. The parasympasis accounts for 24%, weakened by the exceptionally long root of the canine tooth and the structural defect of the mental foramen.
And the condyle accounts for another 24%.
Because its narrow neck is specifically designed to snap when a massive upward force hits the chin, preventing the condylar head from being driven directly through the glenoid fossa and into the middle cranial fossa.
It's amazing how the body is engineered to break in specific ways to protect the brain. But the most fascinating biomechanical aspect of mandibular trauma is the vector physics governing fracture stability, categorized as favorable versus unfavorable fractures.
It's entirely about vector physics. The mandible is essentially a lever manipulated by incredibly powerful opposing muscle groups. The elevators, the masseter, temporalis, and medial pterygoid, exert massive upward and forward pull on the posterior mandible.
And the depressors, the suprahyoids, including the geniohyoid and digastric, pull the anterior mandible forcefully downward and backward.
Right, so when a fracture occurs, the specific angulation of the break relative to those muscular vectors determines the stability.
If a fracture line at the angle runs from posterior superior to anterior inferior.
The upward pull of the masseter actually drives the proximal broken segment directly into the distal segment. The muscular force compresses the fracture tighter. This is mechanically favorable.
But if the geometry is reversed, running from anterior superior to posterior inferior.
It is mechanically unfavorable. Every single time the patient swallows, speaks, or clenches, the masseter pulls the posterior segment up, the suprahyoids pull the anterior segment down, and the mandible literally tears itself apart along the fracture line.
It's like a suspension bridge where the cables have a mind of their own.
Exactly.
Now, what about diagnosis?
Diagnosis relies on the mandibular stress test, applying firm outward pressure on the lingual surface of the body to elicit crepitus or abnormal mobility. Imaging utilizes the Panorex to evaluate the exact relationship of the teeth to the fracture line, while CT is required for the condyles and complex symphyseal fractures.
Now, there is a major controversy mentioned in the text. How do you manage a tooth that is sitting directly inside the fracture line? Historically, the mandate was immediate extraction.
Right, due to the profound risk of osteomyelitis bacteria tracking through the oral cavity down the root into the marrow space. But the modern surgical paradigm, driven by advanced rigid fixation and broad-spectrum antibiotics, has shifted.
So do you extract it and lose the occlusal guide, or keep it and risk infection?
If the tooth is structurally intact, if the root is not fractured, and crucially, if that specific tooth provides an essential occlusal stop necessary to perfectly realign the jaw, we leave it in place.
We utilize it as an architectural landmark to reconstruct the premorbid bite.
Yes, you monitor it vigilantly. If it develops apical radiolucency or clinical infection weeks later, it can be extracted. But sacrificing it immediately removes your best map for the reconstruction.
Right. So while the mandible handles the extreme mechanical forces of mastication, the midface is engineered to handle the kinetic energy of catastrophic impacts.
Yes. Let's look at how the entire face detaches from the skull. The midface is an intricate architectural matrix of horizontal beams and vertical buttresses. Its primary evolutionary function is energy absorption.
Acting as a crumple zone to protect the neurocranium, the evolutionary airbag of the human skull.
Exactly. And our understanding of these crumple zones originates from René Lafort's 1901 experiments. By dropping cadaver skulls to apply varying vectors of massive blunt force, he proved that the midface does not shatter randomly.
It fails along highly predictable, reproducible lines of structural weakness, which he categorized into 3 distinct patterns.
The Laforti fracture, comprising about 30% of these injuries, is a transverse horizontal fracture running right above the apices of the teeth. It effectively separates the hard palate and the maxillary dentition from the rest of the facial skeleton.
Clinically, if you grasp the upper teeth and apply motion, only the premaxilla moves. It feels exactly like a loose set of upper dentures.
Lafort 2, the most common at 60%, is a pyramidal fracture. The kinetic energy strikes higher on the maxilla. The fracture propagates upward through the maxillary sinuses, through the delicate orbital floors, and across the nasal bridge.
The central pyramidal block of the face is entirely detached. On physical exam, when you manipulate the maxillary teeth, you will feel the infraorbital rims and the nasal bridge moving simultaneously with the jaw.
And then the Lafort III is the most catastrophic, representing less than 10%. This is a complete craniofacial disjunction. The fracture line runs completely across the nasofrontal junction, traverses both medial and lateral orbital walls, and snaps both zygomatic arches.
The entire facial skeleton is sheer off the cranial base. Everything moves independent of the skull.
These fractures require massive kinetic energy, typically seen in unrestrained MVCs, or severe falls in middle-aged adults. Interestingly, they are exceedingly rare in the pediatric population.
Because children possess a proportionately massive neurocranium and highly flexible facial bones. Plus, their maxillae are heavily reinforced by the dense crowns of unerupted permanent teeth, and their sinuses are largely undeveloped.
They simply lack the hollow voids and rigid struts required to create the Lefort lines of weakness.
The treatment paradigm for midface fractures has undergone a radical evolution, too. The historical approach relied on delayed repair, allowing weeks for the massive edema to resolve before attempting reconstruction.
But today, the standard is early open reduction and internal fixation, or IF. Because of the physiology of bone healing, if you delay surgery for weeks, the body mounts its own reparative response.
It fills the fracture gaps with dense, organizing fibrous tissue, and osteoclasts begin blunting and resorbing the pristine, sharp edges of the fractured bone.
So when you finally attempt to reduce the bones, the anatomical puzzle pieces no longer interlock. By operating early, before the fibrous union solidifies, the surgeon can perfectly reapproximate those pristine cortical edges.
Apply rigid titanium plates across the buttresses and definitively lock in the correct three-dimensional projection of the face, preventing late-stage protrusion and flattening.
Exactly. And while a pure, isolated Lefort fracture is rare, most high-energy impacts result in complex asymmetrical amalgams of all three types on different sides of the face. The classification remains vital.
It's the standard nomenclature. When a trauma surgeon calls the neurosurgeon and says, "We have a Lefort third," the entire team instantly comprehends the massive force vector involved and the profound risk of skull base and intracranial injury.
Which leads us directly to the upper vault, the interface between the facial skeleton and the brain.
The frontal sinus is the armor of the upper face. It develops late, between ages 6 to 15, and the anterior wall of the frontal sinus is composed of incredibly thick, dense cortical bone.
It is the strongest bone in the face. A fracture here indicates a transfer of kinetic energy so massive that concurrent traumatic brain injury must be presumed.
Diagnostically, you assess for severe localized pain and paresthesias in the supraorbital V1 nerve distribution. But the absolute priority is identifying a cerebrospinal fluid leak, right?
Yes, you must actively look for clear rhinorrhea or ask the awake patient if they perceive a salty metallic taste in the back of their throat. Any suspicious fluid is collected and tested for beta-2 transferrin, a protein highly specific to CSF.
And the management algorithms are strictly dictated by the depth of the fracture.
If the fracture is isolated to the anterior table and is minimally displaced, meaning less than 1 to 2 millimeters of depression, the protocol is observation. You leave the armor intact.
However, if the fracture penetrates the posterior table, communicating with the cranial vault, and there is a persistent CSF leak, the sinus cavity must be surgically eliminated through either cranialization or complete obliteration.
Right. And the rationale for permanently destroying the frontal sinus leads to the delayed catastrophic risk of mucocele formation.
Because the sinus is lined with highly active respiratory mucosa that continuously secretes mucus, draining down the nasofrontal duct.
If the trauma traps even a microscopic island of that mucosa within a fracture line, or if the drainage duct is permanently crushed and stenosed, the mucosa continues to secrete.
And that trapped mucus forms an expanding, encapsulated cystomucocele.
Over years, the hydrostatic pressure of this expanding cyst will slowly resorb the surrounding dense bone. It can erode anteriorly, creating a visible mass on the forehead.
But far more dangerously, it can erode posteriorly directly into the anterior cranial fossa,
resulting in meningitis, cerebritis, or a massive, lethal brain abscess years after the initial trauma. Obliteration involves meticulously burring away every microscopic cell of mucosa and packing the void with autologous fat or cancellous bone.
Okay, moving inferiorly from the frontal sinus, we reach the most technically demanding real estate in facial trauma, the naso-orbital ethmoid, or NOE complex.
The absolute focal point of this region is the medial canthal tendon. This robust tendon attaches to the frontal process of the maxilla and anchors the inner commissure of the eyelids.
Its primary biomechanical function is maintaining the precise intercanthal distance.
Right. The normal intercanthal distance is rigidly maintained at 30 to 35 millimeters, which correlates to roughly half of the patient's interpupillary distance, or the width of their alar base.
When massive anterior force shatters the NOE complex, that medial canthal tendon is displaced or entirely detached.
The tension holding the medial orbits together is lost, and the soft tissues drift laterally.
The resulting deformity is telecanthus, a severely widened and flattened appearance of the eyes. It is aesthetically devastating and incredibly difficult to correct in a delayed fashion.
You diagnose NOE disruption clinically by applying firm lateral traction to the lower eyelid. If the tendon is intact, you feel immediate, firm resistance.
If the tendon is detached, or the bone fragment it attaches to is floating freely, the eyelid pulls away with zero resistance. It's like cutting the center rope on a tent.
Everything just drifts outward. NOE fractures are classified by the integrity of that central bony fragment. Type I involves a large, central, solid fragment of bone with the tendon still firmly attached.
Type 2 fractures are comminuted, but the tendon remains attached to one of the larger floating fragments.
And type 3 is the most severe and complex. Severe pulverization of the bone with the medial canthal tendon completely ripped off its bony insertion.
Repairing a type 2 or type 3 NOE fracture requires exact precision. You must physically retrieve the detached tendon or its bony fragment and meticulously re-anchor it. This requires transnasal wiring.
You pass a wire completely through the nasal septum, connecting the right and left medial canthal tendons. You draw them together, slightly over-tightening them past that 30 to 35 millimeter mark to account for eventual soft tissue relaxation.
Once the tension is set, you utilize micro-titanium plates to painstakingly reconstruct the shattered ethmoid and nasal scaffolding around the wire.
All right, let's run a few scenarios to synthesize all these mechanics. Put you in the hot seat?
Let's do it.
Okay, scenario 1. You are the trauma surgeon on call. EMS brings in a patient who sustained a severe assault outside a bar. They are highly intoxicated, supine on the backboard, actively vomiting, and exhibiting obvious bilateral parasymphyseal mandibular fractures with a grossly unstable lower face. What is the immediate sequence of events?
The sequence here is immediate, aggressive airway capture driven by the anatomical cascade. The bilateral parasymphyseal fracture means the genioglossus has lost its mandibular anchor. The tongue is actively dropping into the posterior pharynx. The acute alcohol intoxication blunts the cortical gag reflex.
Right.
And the vomiting, combined with the supine position, guarantees massive aspiration of gastric contents if unaddressed. I would immediately roll them laterally, assuming the cervical spine allows, to let gravity clear the emesis. Suction aggressively.
Good.
Given the catastrophic loss of lower jaw stability and the act of vomiting, you proceed straight to rapid sequence or tracheal intubation. If the pooled fluids and tissue collapse obscure the cores, you do not attempt a blind nasal tube. You immediately perform a surgical cricothyrotomy.
Excellent. Okay, scenario 2. Let's look at the orbit. You are evaluating a patient with a direct blow to the zygoma, resulting in a ZMC fracture. They complain of profound diplopia, specifically on upward gaze. However, you review the coronal CT, and the orbital floor fracture shows only minimal 1 millimeter displacement.
Okay.
The question arises, shouldn't we just observe this, allow the orbital edema to resolve over a week, and see if the diplopia improves rather than rushing into the delicate periorbital space?
So wait, if it's only a 1 millimeter displacement, is waiting for the swelling to go down safer than rushing into the orbit?
The counterpoint to observation lies entirely in differentiating edema from ischemia. A minimally displaced trapdoor fracture is actually far more dangerous to the extraocular muscles than a massive wide-open blowout.
Ah, right, because of the pinching.
Yes, in a trapdoor mechanism, the elastic bone snaps out, the muscle drops into the crack, and the bone snaps violently back into place. It pinches the muscle tight. You must perform forced duction testing.
If the globe rotates freely, it is neuropraxia from the impact, and you observe.
But if there is a hard mechanical stop, the inferior rectus is incarcerated. That tight bony pinch chokes off venous outflow, causing rapid compartment syndrome within the muscle. You must operate emergently to release the muscle before irreversible ischemic necrosis sets in.
Exactly the right physiological rationale. Okay, scenario 3. You are managing a torrential posterior epistaxis. You have inserted a 14 French Foley catheter and inflated the balloon to the mandated 10 milliliter. You retract it firmly, but a slow, persistent trickle of blood continues down the posterior pharynx.
Okay.
The text says 10 milliliters, but the bleeding isn't fully stopped. What is the risk of just injecting another 5 or 10 milliliters of saline into the balloon port to increase the tamponade pressure?
You absolutely cannot overinflate that balloon.
Mm-hmm.
The 10 milliliter volume is a rigid ceiling. The posterior nasopharyngeal mucosa is trapped between the unyielding bony skull base and your balloon. If you increase the volume to 15 or 20 millimel, the outward radial pressure of the balloon will rapidly exceed the capillary perfusion pressure of the mucosal bed. You will induce severe ischemic necrosis within hours, destroying the structural integrity of the posterior choanae.
So what do you do instead?
If 10 millimel fails to arrest the hemorrhage, you add firm anterior ribbon gauze packing to increase the counterpressure against the correctly inflated balloon, or you transition to direct bipolar or chemical cautery. You never sacrifice the tissue viability for pressure.
Synthesizing the evidence from Desai and Thaler, the actionable directives for the trauma surgeon are absolute. First, anticipate early, rapid airway loss in comminuted mandibular and maxillary fractures due to the mechanical descent of the genioglossus, and prioritize definitive orotracheal or surgical airways.
Second, strictly adhere to local anesthetic maximums, 4.5 milligrams for plain lidocaine and 7 millimolekilograms with epinephrine to leverage vasoconstriction while avoiding lethal systemic toxicity during massive closures.
Third, rigorously apply the Lukowitz algorithm, cannulating Stenson's duct for any penetrating trauma crossing the mesenteric trajectory.
And finally, recognize the paradigm shift toward early open reduction and internal fixation for midface fractures. We must intervene before fibrous union locks the malaligned bones, utilizing rigid fixation to perfectly restore the three-dimensional architecture.
Maxillofacial trauma demands that we treat the face not as a cosmetic afterthought, but as a highly complex, interconnected biomechanical system. And there's a profound paradox to consider as we close.
Yeah, the crumple zone paradox.
René Lefort proved that our facial skeleton evolved specifically as an energy-absorbing crumple zone, designed to shatter at precise weak points to prevent lethal kinetic energy from reaching the brain.
Right.
Today, our definitive reconstructions utilize heavy, indestructible titanium plates and rigid screws to perfectly rebuild that midface. By reinforcing the face with unyielding titanium, are we inadvertently obliterating the patient's evolutionary airbag?
If that patient suffers a second massive deceleration impact years later, that kinetic energy will no longer be absorbed by the shattered maxilla.
It will bypass the titanium buttresses and transmit directly into the cranial vault. We fix the anatomy, but we fundamentally alter the physics of the next impact.
Think about that the next time you lock a rigid plate across the nasofrontal junction.
Thank you for joining us for this deep dive. The operative management of these injuries requires absolute precision, but armed with these structural algorithms, you can secure the airway, arrest the hemorrhage, and definitively rebuild the architecture. Keep your edge sharp.